Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from SK Life Science, Inc. This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
Hi, welcome. My name is Dr. Jim Wheelis. Welcome to our update on the use of anti-seizure medication in the management of Lennox-Gastaut syndrome. I want to introduce my two colleagues who will be joining me today. Dr. Kate Labiner and Dr. Amanda Pond will be active in the discussion, and also will have case presentations during this that they'll give you that will create kind of a background for how do we approach treating folks with Lennox-Gastaut syndrome. Before we get into that, I wanted to give a little bit of background on just treating Lennox-Gastaut syndrome, our goals, and look at kind of where we've come medically and what options are available for our patients. So our goals in treating these patients, we realize that these folks are going to need lifelong care, typically, often with adjustments to their anti-seizure medications and other treatments over time. But we'd like to minimize what we call their most disabling, or you can call them dangerous seizures. So the ones that either they end up in the emergency room for because of convulsive activity, or drop attacks where they could have medical injury from those seizures. And obviously, when we do this, we're always balancing, knowing these folks are on multiple medications, seizure medicines, potentially other medicines, their whole medical burden, trying to minimize sedation, evaluate for drug interactions, and basically trying to improve their quality of life as much as we can during this process as well. So this is really, these are challenging patients, but this is where really the art of medicine comes into it with these patients. If we look at the options and where we are with seizures in these folks, we have multiple seizure types that they could have. These may vary, and they typically do over their lifespan. So it's not usually a constant, but if you look, you can see that, gosh, almost every seizure type you can think of, with the exception of kind of classic absence seizures, occurs in this population. This is why we often are challenged with treatment and why they're often on a polypharmacy. And it's really the challenge we face as clinicians in working with the family, just kind of knowing what seizures they have, what we're actually targeting, and what medicine is hopefully accomplishing, which seizure type it's controlling. So with that background, maybe I'll turn to my colleagues. This is a challenge, so maybe ask them when they are seeing patients, and once this diagnosis has been made, and they're talking with the family, how do they approach them about just getting these concepts across to families?
I
And I'll
think for me, one of the most important things that we can do is really meet the families where they are for this, because for some of these kids the goals are a little bit different than it's going to be if you have a kid with a primary absence epilepsy, for example, where the goal is then going to be seizure freedom. For some of these kids, seizure freedom isn't really the goal, and so it's about the quality of life. How are they doing on the medicines? And of course, then what seizures are going to be, as you said, like the most disabling or most damaging for them. And for Some of those parents, it's the atonic or the spasms because the kids are dropping their heads and hitting their heads, knocking out their teeth, not able to go to school because they don't have a one-on-one aide to help them. And then for some of the older kids, it's about balancing the medicines more even than the seizures because they are going to be needing to be awake more because they are at school. We want them to participate and kind of balancing that.
Yeah. Amanda, do you want to comment on kind of the challenges
Yes,
that we
absolutely.
face? Yeah.
Um, so the challenges are very real, and they're obviously just multidimensional. But I actually want to present a slightly differing view because I do think in the very recent stages of anti-seizure medication development, seizure freedom is an absolute thing that we should at least talk about because it is an option for many of the children, particularly, as I see children, but even adults. And this is evidenced in the couple of papers that came out last year, including from us, with particular newer drugs. So I never want to, one of my age-old mentors had said, never to take away hope. So I think, some of the things we talk about today may challenge some of those teachings as well. So just to keep an open mind. Yeah.
Yeah, I think this is always a challenge, right? Because
Yeah.
it's yes, we would like to, at a minimum, make sure they're not having vol seizures, not having drop attacks. Can we get rid of every myoclonic twitch, every atypical absence to some of these folks? To your point, I think we all kind of say, okay, if there's a reasonable option that can help you and that's what you're having, um, yes, it's worth trying, and we all continue to try as new things kind of come out. But I think the flip side of that, in my clinic, I know when we see these refractory patients, is we probably more often take away treatments than we add treatments because we often see that they got medicine after medicine added. They're on 4, 5, 6, 7 drugs, and just the sedation alone from that could be making the seizures worse. So I won't tell you that I hit it every time, but we try and say for these kind of patients, let's not have them on more than 3 anti-seizure medicines if we can. Do I have some that are up past that every time I try and back off, things get worse? Yeah. I'm gonna take the prerogative as okay and switch to kind of the treatments as we've got into this, kind of where are we with treatments? Then we'll get into the cases here. So yes, we've had medicine for a long time, but historically before that, we were using barbiturates, phenytoin, gosh, even opioids were used. I mean, the patients were basically just sedated because that was all we could do in having seizures. We luckily in the modern era have had a explosion, if you will, of therapy options, which is great. We still need more. Don't get me wrong. We'll hear about that some today. But we do have options, which has been great that are tried in these patients. We have a sense of like how well do these work, what seizure types are they targeting, drug interactions, dosing. So it's great that we've had real trials with these agents. We do have other medications that we'll hear about that have been used off the label, maybe not formal randomized trials, but may have a place here as well too. And valproate, as you can see, when it came into use in the 70s, was really the historic standard, if you will, because when it came about, it was the first option we had that wasn't sedating. So it's a historical standard, if you will, in this entity as well. We think about that use here as well. So with that background, we're going to maybe shift gears a little bit, and I'm going to let Dr. Leviner kind of move on with her case and just kind of walk you through the challenges not only we face in just these tough patients, but kind of also in matching the medicine to the patient, which is what she talked about.
Uh, So my case is from my own patient population, and he is a little boy who we actually started seeing at birth for brain malformation. So those were seen in utero, and he had MRIs and that whole workup, and everything was actually going pretty well. And the focus of a lot of his early care was actually on his cardiac disease. And when we get into his etiology here in a second, we'll talk about how those play into each other and how that's been a challenge for him in terms of treating his epilepsy because we have to watch the cardiac part so closely with a lot of the medicines. So at about 8 months of age, he came to see me in my clinic, and it was actually just for follow up. The parents had not said that they had seen any seizures, and I will never forget. He was sitting on his mom's lap, and I watched his head drop and his arms come up in the office. And I said, "Oh," and then he did it again. And I asked the parents, "Have you been seeing that?" And they said, "Oh yeah," and they had mentioned it. I was concerned that they were spasms, especially given his history. So we said, "Okay, you have this pachygyria, polymicrogyria picture on your MRI with agenesis of the corpus callosum, which is not necessarily an epileptiform or epileptic thing that we're looking for, but of course the pachygyria and polymicrogyria we do see very frequently epilepsy with those malformations." So we got an EEG and confirmed electroclinical spasm. So both the EEG and then clinically confirming that with hypsarrhythmia initially. And so we started him then down this pathway for treatment and have now kind of ended up in a place where he has a combination of epileptic spasms with a real Lennox-Gastaut type picture, although the hypsarrhythmia is not really there anymore. And so when we did his genetic testing, he has a TUBBA2 mutation, which is one of the tubulonopathies. And so that is going to affect many different parts of his picture overall, because now he has lots of cardiac disease. Like I said, that had been a big focus for him. When we started having the spasms, we went down the process of how do we treat spasms and those very kind of classic electrographic hypsarrhythmia spasms. And so we started him on steroids, but I will say this was a big challenge even to get my cardiac colleagues to agree to let me do that because they were concerned about the effect that it was going to have on his heart and his blood pressure. And so they wanted to be very, very gentle in it, much more gentle than we would have been, I think, if it was just from an epilepsy standpoint, what we were going to do. He then gained a ton of weight, which was also not thrilling for any of us, especially at cardiology. And so we then started to wean it for him. He was also very irritable on it, which we'll see as a common theme for him, which has made his case a bit more challenging. He got switched to topiramate as that at that point, which was ineffective for his spasms, and his EEGs were continuing to show epileptic spasms with that LGS picture and not hypsarrhythmia. He's actually never gone back to a hypsarrhythmia pattern after the time of the initial ones. And as you can see, we've gone through a bunch of different trials with him, and really the biggest issues we've had have either been that he can't take certain ones because of his cardiac complications, or it's been that we've had these other factors and a side effect standpoint coming through. And irritability has been the biggest one for him. He actually, on a couple of them, including most recently when we had him on a trial of rufinamide, he had vomiting, but then also he was getting these new like startle myoclonic seizures that we hadn't seen before and was really sensitive to his younger siblings, so that anytime they would start to cry, he would start to have a bunch of seizures. So we had to then pull these off. He was very sedated on the benzos. It actually helped his seizures immensely, but he was not awake enough to be able to participate in his therapy regimen. He wasn't awake enough to be able to really participate in life, which of course we didn't want to continue then. Valproate and brivaracetam were ineffective. They actually almost had no change in his seizure burden at all. He got started on the ketogenic diet, which is often a thing, especially for him. He's G tube fed, so it's an easier thing for us to be able to do since we don't have to worry about the limitations of eating by mouth or not eating by mouth in this case. And he got up to a 3-to-1 ratio. It improved his seizure burden initially, but the GI issues became really, really complicated. He was horribly constipated, and so we were having to add in now extra medicines just to treat his constipation, even though then the seizure burden, we kind of decided maybe that was not helping enough. He also started vomiting anytime we went on higher up on his ratio, which then made him start to cry if he even heard the buttons from the pump. You're now more emotional. You're going to have more seizures then too. So we ended up then tapering off the diet. He has tried, as you guys will see, a bunch of different medications. Vigabatrin was actually very effective for him from a seizure standpoint. But unfortunately, with some of these, I think there's a lot of misunderstanding at times on what the other side effects that we need to watch for from our colleagues. And so vigabatrin has that risk of visual impairments. And so they can lose peripheral vision from that. But unfortunately, when he went to go see an ophthalmologist, they told mom that he could get cortical blindness from it, which is not true, and didn't want to continue on it. And despite going and getting a second opinion, we just couldn't kind of bring that back in. But to get him to a seizure-free standpoint, outside of when he was on steroids initially and then vigabatrin, he's actually never gone back to that point. He's gotten to seizure-free days, but the longest we've ever really gone is like a few days, usually in the 3 to 4 day range. And then they'll come back. Currently, he's averaging about 30 seizures a day in clusters still, epileptic spasms. EEG remains that Lennox-Gastaut pattern. He does have a VNS, which they feel like helps when they swipe the VNS, but again, not as much when it's just being the regular settings of it, have not seemed to make a huge difference. And that he gets more irritable when we've tried to go up onto higher settings with it. He's been on cannabidiol, which while maybe has helped his seizure burden some, the biggest advantage we've had is with his constipation, that it's actually helped that more than anything else. And so really we work with the parents to kind of balance out what side effects can we accept when we're not necessarily the ones that have to live with it, right? For this family with 3 young kids to have his younger siblings not be able to be in the room with him because they would cry and he'd get upset really isn't a tenable situation because, of course, they all have to live together.
Yeah, you bring up a lot of the challenges that we all face with these kids, and I think at the end of the day, it sounds like your discussion is probably close to the one that we all have, which is at this stage, which is what seizure types are we currently experiencing, and then, gosh, what are options that are left for those, and then the one that you've, I guess, alluded to is if I always kiddingly tell families, if I had a magic wand and I could wave it and get rid of these, what would change in your child's life? Because I think they say things that you alluded to, like, oh, it would make it easier for us to do family things together. Other than that, those kind of things, yes. But if they say, oh, our child will be able to attend normal school and drive, and it's a kid like this, do you know if that's unrealistic? Then it does help me with just having a discussion without being harsh. This is sometimes that quality of life balancing act, and it doesn't mean that's where you'll always sit, but it just means okay for the time being, unless that balance kind of shifts, we're here. All right, Amanda, maybe we should move, and we'll switch to your patient, see how you approach them.
Yeah, so this case really just popped in my mind because it was sort of an index case for me. It's the first time this type of thing had happened, and then subsequently there were others. So this is about an 8-year-old girl, and she came to me when she was 8, but actually her story started when she was 4. So she was actually an exceptional child, nature lover, lived on a farm, did all kinds of things, was a great competitive gymnast, whatever that means at age 4, and sung all the nursery rhymes and was really quite bright. You look at their pictures with the siblings, and there was nothing that would have told them apart, right? But suddenly, one day the mother noticed that she was dragging her foot. Another day, she noticed that she had vomited in the back seat, but we're not really sure why. And then other times, she would just appear unable to converse in her usual way. So just a very variety of different presentations, but not coming from an infantile spasm or other seizure stories such as the previous case, right? So it always comes with a little bit of a delay when it's a little bit subtle like this, and we don't necessarily suspect seizures straight off, and so there's always this problem. But um, unfortunately, with her, it was actually subsequently very explosive, and there was not much doubt after just a couple of months that there were many different seizure types involved. So her EEG was showing a typical LGS picture, which I won't go through, but she was having many, many different seizure types. Her seizure count went up to 40 per day. According to mother's quote, she was either seizing or asleep pretty much her whole life then. And she could still walk and she could still speak, but it was very zombie like. She was just deeply what we call encephalopathic. She was never that far off from having a seizure. So at this point, I saw her And when I see a child like this, I was trained by Dr. Blaise Bourgeois, and he has a grid. And I use this grid, and it helps you outline in chronologic order every single seizure type that people have had, what med was used to treat them. If you know it, things like the serum blood levels, good effects and bad effects of every med, and going in order like that down through time. And it was so impressive because now in the day of cell phones, this mother had every single data point of every single appointment on her cell phone. And as fate would have it, she was my last patient on a Friday evening, and we spent 4 hours and we hashed the case. And her grid was 4 pages long. But even if you don't have such great level of detail from a parent on your first visit, um, I was able to think about what kind of mechanisms she had been exposed to in terms of the drugs. How do they work, right? um, and think about what things she had not been exposed to that might still work for her, or if there's some sort of a reasonable combination using something that she liked, did well with, and maybe something else, right? There's a couple meds that are very commonly dispensed. Someone who's not a specialist may send them. So this is something that marked the beginning stages of her story because it wasn't clear where she was going. And she was exposed to a carbamazepine type drug, which produced worsening. We know this can happen with carbamazepine and such type drugs in LGS. If you have a kid who has seizures, it's always best to check a series of EEGs because we know from data from the 80s that they will change over time. Your first EEG is not your last. And in 6 months' time, by Camfields and everyone, it might be different. So that makes it hard in the early days, right? Because then you're making decisions on not such great, strong data yet. But she did, luckily, get to a different medication, or levetiracetam, sometime fairly soon after that. And she had a nice period of seizure freedom for 15 days. But unfortunately, as people have alluded to, side effects kicked in, behavioral issues. Now, we do have newer medications that try to avoid things like that. So nowadays, there would be brivaracetam. And then she had a history that was quite prolonged, which I won't go through, with many different other medications. I think the total was 14. So can you imagine going through this odyssey of 14 different trials, sometimes in combinations and so forth, that might not be helpful either. But the end of the day, there was nothing that was clearly improving her. And sometimes you can't even tell if there was or was not a good effect because there was a combination involved, right? Um, so when she reached me, we had gone through her history. I double checked her EEG. It was clearly LGS. She was indeed having 40 to 50 tonic and other types of seizures per day. She did have lots of um, previous injuries and so forth from falling. And we talked about her choices. This family had already been well into that second tier where you're thinking about things like surgery, stimulation, trials, new medications, and such. They've been through diet, different versions, which had not been helpful. And they had also been through a surgical evaluation, but that didn't give them a very positive evaluation or a path forward, and the family did not pursue that. Also, when they met me, they were pretty adamant that we're not in a place where we're willing to think about opening anything. So, um, so the discussion at that point hinged on a couple of things that they had not been exposed to, right? They had not been exposed to, for example, the newer type of medications which work at serotonin, at which point the only one available is fenfluramine. And they were also there was also a number of LGS trials that were either available or coming at that time. When you have been through an odyssey of 14 medications and you're faced with three choices, you really don't want to do anything that eradicates any of the three choices. So, for example, if there's something with a limited time availability and the other ones I can still get them next year if that first thing doesn't work out, then I might go that way. And that was pretty much how that discussion went. So, um, there was at that time enrolling a trial for Lennox-Gastaut, also Dravet, and it was for a drug called Cetuclastat. Um, so the family decided to go for this, and she had been through rigorous testing. So we didn't have a known etiology for her. Imaging normal, all the ranks of genetic testing, panel, whole genome, mitochondrial, chromosomal, had all been negative repeatedly. And there was no specific indication as to which mechanism is going to really benefit you, right? So at the end of the day, we had to go with the several things that she had not been exposed to. And she actually went into the trial. And of course, there's a period in the trial where you are blinded. But even in that phase, she, within a couple of weeks, had a marked decrease in seizures and no daytime seizures by about a month, no nighttime seizures in about 2 months. So we did her EEG at 2 months in, and it was actually normal. And supporting what we were seeing clinically, which was that she started to talk again. She sort of woke up. She started singing nursery rhymes that she had learned at age 4, but it was 4 years later. And, at the end of these trials, the kids are oftentimes given the opportunity to continue on the drug in an open label way. And sometimes you have to like drop down a little bit and then go back up. And during that day, when she dropped down, just one dose dropping down, she went into near status. So a lot of phone calls, a lot of running around, please change the protocol, something. And then that night she got her med back at the full dose. And the seizures went away because just like case one showed us, sometimes when you're seizure free, it doesn't mean you always will be. And it can be very tenuous, even if you take away the same med that did it and then put it back on. At the end of the day, unfortunately, this drug was not strong enough in its numbers to be passed. We did advocate for the family to get access to it for as long as, the stores of it would hold up. And they were promised a good 2 years worth of it. But the family said she's actually had, at this point, 7 3-day-long EEGs that have been clear. She's doing great. She's back in regular schools, sleeping by herself. And they said, well, maybe we want to see if we can just slowly, slowly come off it and do an EEG every so often as we're going down, just to herald any negative things that may be happening. So that's what we did. She's been seizure free. She's had all these normal EEGs. She does have some mild delay. She will need help with small print on her rental contract when she goes up. But she has a life that they did not anticipate could be possible. So I think that's just kind of amazing. And I think there's a lot of spread of potential outcomes in these cases. And as I mentioned, she really was my index case. And for whatever reason, with not just this one, but some other cases, we had other kids who did well with this drug, but also with other newer drugs. Cenobamate, fenfluramine, particularly sometimes prampanel, we've also seen some very nice things. And I think it has to do with just finding that golden place where they do well, making one change at a time, being very rational in our polytherapy, and not being afraid to try things that come along that are different, right? Because they're not just all the same thing over and over again.
I think your patient reminds us of what we all know, but sometimes just this is a good reminder, which is that Lennox-Gastaut is not a single entity. Both your patients demonstrate that clearly. It's made up of, the patients come to it from many different backgrounds. I would love it. I kiddingly tell the family if someday a patient would come in and say, oh, I respond to this type of mechanism, but they don't. And there's no test I can do for that. But then the flip side of that coin is, well, our patients have all these different ways to show up with Lennox-Gastaut, and we don't know which is their mechanism. The drugs we've talked about all work very differently too. So it's interesting, kind of clinically, we've come to the same point kind of accidentally, if you will, or fortuitously, in that the drugs that are being used, we don't have Me Too drugs here. They all work very, differently with different mechanisms, yet they all work. And so it's like, to your point, it's kind of fitting that mechanism with that patient, and that's the trial and error aspect. And I think I may, if everybody's okay with it, take a prerogative here because just for a time standpoint, and with that note, maybe say, let's look at some of the medicines that are used that are we recognize as off-label but are used there. And maybe, Mandy, you could take the first one, just kind of when you've used that there, what is your thought? What's your trigger for seizure type? What do you tell families,
Yeah,
common side effects? Maybe just a couple of the highlights that you tell families.
absolutely. So one of the ways that I do this is I say, look, this is not about you or your child specifically, but in the trials, which were very well monitored and very similarly designed, at least for your phase threes, we have certain numbers that we can at least try to approximate them. Which one is giving us a standout number? So for our day and age, we have a couple of things. We have fenfluramine, but then you also have a lot of trials that are done in people with drug refractory epilepsy, generally adults and so forth, that end up giving us numbers that we can compare as well, if we don't have direct numbers to say in LGS, because sometimes the trials don't track what we need in real life, right? So for efficacy, cenobamate is really one of the highest hitters because it produces seizure freedom numbers. And I'm not saying this is true about your patient, but when the other trials produce numbers like 3 to 5%, cenobamate would produce numbers like 21 to 29 to 31%. And so that's, to a parent, is showing the sort of just a simple numerical thing that they can maybe think about. Um, and uh, and so if you want to hear about things that are more likely to produce seizure control, help you bring down your overall seizure medication burden, which is very important, and also be tolerable if we use it in the right way, thinking about interactions between drugs and all that, then this is something to consider. There are, of course, different types of seizures that we're thinking about. And the whole literature of cenobamate and LGS in particular is sort of new and growing. And we sort of put out our little bit of data last year as well, for both children and adults. And just speaking from that, we did have just only 16 patients. This is all very new, happening in real time, but 8 adult, 8 pediatric. But we did have 5 who were seizure free, and um, they were all on the younger side. Okay, so they were mostly children, for whatever reason. Okay, with a variety of genetic etiologies, and all tested with all the 4 modalities we mentioned above. So there were a very high number of responders to this, and when we say responders, we mean a decrease in at least half of the seizure frequency. And there was also uh, a significant seizure freedom, or control of about 85% of the patients in terms of tonic seizures, which lasted for a significant period of time. And there were some patients in the many series that were published that have had sustained seizure freedom. At this point, we're only talking a year or two out, but this is interesting, right? So, and then of course potential side effects, and I always say potential because you might not have any. But there were around half of the patients, or possibly more, would have issues with things like sedation and dizziness. This is something that does work at the sodium channel, even though it's different. And there were some, especially I think with the older folks, who had more issue with behavioral irritation. Um, so these are things that can be that are definitely transient. If you stop the medication, that stuff will go away. So it's much better than telling someone you're going to have, weight gain that's very hard to shake, or a liver problem or a heart problem. Yeah, so that's what I have for just a little overview of how we go about that.
Kate, do you want to maybe chat about? I think your patient was exposed to it, but I mean, it's another approved medicine. It's one of our newer ones. It was Amanda alluded to, but just fenfluramine, and kind of where you put that in for your LGS paradigm, or how you talk to families about it.
So even Amanda alluded to earlier when we talk about looking at the mechanisms, and I actually tell parents that the definition of insanity is doing the same thing over and over and expecting a different result, right? And yet we see this, and I think especially as epilepsy providers, we often see that coming from the community, right? As people who are not necessarily parts of these studies, knowing what's coming out in the epilepsy world, and you'll see a kid who has been on 4 different sodium channel drugs, and you're like, well, the first 2 didn't work. Why did we think the second 2 were? And so really talking about the reason we're picking this is because it's different, right? It's not because it's we have necessarily said, yes, these are going to fail. And also too, as Amanda said, making sure that we're avoiding things that we know can make things worse. Same with the side effects. And fenfluramine, we were lucky enough to be a trial site for fenfluramine. And I think for a lot of these kids, especially when we're talking about injuries related to seizures, that was where we saw a huge improvement in the drop seizures and those atonic spasm type seizures that the kids were having. I think that 26% had a median reduction. And that's huge when we're talking about ones that we are concerned are going to injure kids. And like Amanda said, when for cenobamate, when you start talking about 25, 30%, amazing. And to sustain those rates, which is what they saw with fenfluramine, and we've seen with some of the other newer drugs too, that you see sustained rates a year out, to year and a half out, 2 years out, then being able to stay on that. And I use that for myself too as a way to get parents to kind of buy into this is that we have patients who aren't getting off these meds. And the reason for that is because they're working. And so that while maybe it's not 100%, they're not getting off them for other reasons. They're staying on them. And that I think can be a really powerful kind of push for that to say, we know that this can help for multiple different seizure types. And fluramine, right? The drop seizures were the big ones, but also they saw improvement in the GTCs and the tonics. And so across the board, they were helping. And especially, I think it can be hard for people because the ones that I worry about from the standpoint of injury are going to be the atonic and the drops. But for a lot of family members, it's the GTCs that are really bothersome to have to watch. And it's hard to watch someone you love go through these things. And so to be able to say, we may be able to hit a bunch of different seizure types with one medicine that's working differently than everything else that you've ever tried, I think can be a really nice way to intro new things. And especially for parents, I think of kids with really refractory epilepsies like LGS, like Dravet, that a lot of them are kind of okay with where they are if they're just having seizures when the kids get sick, or, oh, we only see them in these certain situations. And I like to say, at any point, we can also try to make it better. And that if you are in a good place and we're all good with where we are, then is it okay to just ride that out for a little bit too and really focusing on, yes, these are all the options we have, and making sure that they know it. It's not going to be random. We're not guessing. We're guessing with purpose and saying, I am hopeful this one's going to work because it's different. I'm hopeful this one's going to work because it's targeting these specific things. And then also using them in conjunction with each other and knowing when there are synergistic components to it, like steripental and clobazam, like cenobamate and clobazam. Can we use these things together to help in a way that we can't necessarily help with just one?
I love that you spoke about the purposefulness of it, right? Because this is all a discussion. We don't usually even reach a decision necessarily on the first visit.
All right, I'm going to finish up just reminding folks about three other medicines we haven't mentioned, but ganaxolone, approved for seizures with CDKL5. I'll just remind you that before we had genetic testing, all of our patients with CDKL5 actually fell underneath the LGS umbrella, if you will. Once we have genetic testing, we pulled them out as the CDKL5 deficiency disorder, CDD. So they're still kind of loosely part of that LGS group, but ganaxolone was approved efficacy, again, targeting drop attacks. So we keep that one in mind as well. Stiripentol has been used in a lot of developmental and epileptic encephalopathies, including patients with LGS. Now that is available in the U.S., it's been around for a long time, so we understand its side effect profile and its dosing. So clearly an option to help with the kind of convulsive seizures there as well. And then zonisamide. So I know people often think of this and topiramate kind of interchangeably sometimes, but a different drug. But again, one to keep in mind in this population. It's been around. It's been used off-label here. We know it can help with the motor seizures and known side effect profile. So we can talk to families about what to expect and where that when they use that medication. So I'm going to finish up on behalf of my colleagues, Dr. Pong and Dr. Labiner. I want to thank everybody for participating in this activity. I hope that this update on kind of where we are with using anti-seizure medication to help manage our patients with Lennox-Gastaut syndrome has been helpful to you. And there are other tools available as part of this Medscape education program. Thank you.